Good evening. It is my honor to introduce to you Dr. Holly Gilmer. Dr. Gilmer is a board-certified neurosurgeon specializing in a number of complex conditions. She attended Harvard University and the University of Michigan Medical School and went on to complete her neurosurgery residency training at the University of California, Davis Medical Center. After her residency, she completed a specialty fellowship training in pediatric neurosurgery at Children's Hospital of Michigan and a second fellowship in peripheral nerve surgery at Louisiana State University Medical Center. Dr. Gilmer is an associate professor of neurosurgery at Oakland University William Beaumont School of Medicine, through which she is actively involved in teaching medical students and neurosurgery residents. In addition to her academic participation, Dr. Gilmer is also director of pediatric neurosurgery and trauma at Beaumont Royal Oak and medical director of the Beaumont Chiari Malformation Clinic. Dr. Gilmer's clinical activities include specialized interests in pediatrics, Chiari malformation, tethered spinal cord syndrome, hydrocephaly, neuro-oncology, peripheral nerve surgery, including brachial plexus injury, and craniofacial reconstruction. Professionally, Dr. Gilmer is an active participant in the American Society for Pediatric Neurosurgery, the Peripheral Nerve Task Force of the AANS-CNS, the American Association of Neurological Surgeons, the Hydrocephalus Association, the Congress of Neurological Surgeons and Women in Neurosurgery, among others. She currently serves on the board of AANS. In addition to all her pediatric patients, whom she refers to as her children, she is also the mother of a teen son and a preteen daughter. Thank you all for being here tonight. Dr. Gilmer, thank you.
Thank you to the Chiari and Syringomyelia Foundation for hosting this event and inviting me to speak today. So, tethered spinal cord. When we think about tethered spinal cord and spina bifida and dysraphism, this is really how it starts. So this is an open spina bifida in a newborn, and this is not blood. This is the spinal cord, which is open like a flower, like a tulip. So the spinal cord didn't roll up the way it's supposed to into a tube. It only rolled up part way. Then these edges fused with the primitive skin, muscle, and kind of abnormal tissues, and just stayed that way. Sometimes the defect is not open entirely like that. Sometimes it's closed over either by skin or by a thin layer of dura like this that's just bulged out with fluid. So then what we have to do in surgery is to mobilize sharply the placode, the edges, roll it up into a tube here, sew it up with very fine sutures, and then essentially excise the skin and pull it together. But this here is the defect in the back, in the muscle, in the bone, where the spinal cord is coming out. That's an open spina bifida. Closed spina bifida, when we open the skin or open the thin layer of tissue over it, we really find the same thing. Sometimes it's occult dysraphism, and this is a newborn, and you can just appreciate a little bulging here, and it's in the midline, which is very important. Anything related to a tethered spinal cord or dysraphism will be midline, but it may not be at the same level that the spinal cord is tethered. So this ended up being an open defect underneath with a tethered spinal cord underneath. Sacral dimple, we've all heard about. This is a more, abnormal example in a newborn, but again, midline. Traditionally, it's been stated that anything that's below S2, or the second sacral segment, doesn't have anything to do with tethered cord. And clearly, this is not true. This is almost at the end of the coccyx. So again, it really may be almost at any level because the defect can track up, or it may not be exactly over the bony defect. But if it's midline, then it's a concern. And then this is another example, very subtle. A little hemangioma here, little red dots in this little girl, but again, midline, right about L5, S1 level. And she had a tethered cord, which was a little bit higher. So what is the problem with tethered cord? The spinal column, the bony spinal column grows faster and longer than the spinal cord itself. And the spinal cord is supposed to stretch as a child grows. If it's stuck to something, then it can't stretch and grow with the child, and it actually gets stretched in an abnormal way, which can cause nerve damage and spinal cord damage. So the site where an open spina bifida is closed, the scar there, can cause tethering. Bony abnormalities within the spine. Tumors can tether the spinal cord, and that's where the spinal cord lipomas come in. Or just a thickened phylum terminale, what we call a fatty phylum. There's always some fat signal within the phylum, but when there is a lot of fat, fat is not elastic, so it doesn't grow and stretch the way it should, and that's why those are tethered. So this was first described in 1953, not using the words tethered cord, but describing basically a thickened phylum, which was tight, and the mechanism was postulated as longitudinal stress within the spinal cord, actually causing abnormal tissue metabolism, loss of blood supply, leading to neurological deficit. And then they had found that untethering that thickened phylum led to improvement. Harold Hoffman's group in Toronto coined the term tethered spinal cord in this paper from 1976. And then Shoki Yamada's group at Loma Linda further expanded the term to include tumors, bony abnormalities, and so on. So what happens, this all occurs right around weeks gestation 4 to, it varies 4 to 6 or so. So you know that the open spina bifida defect happens between the 3rd and 4th week of gestation. So really that's why women who are encouraged to take the prenatal vitamins before they even know they're pregnant if they're trying, because by the time you know that you're pregnant, it's actually too late to prevent an open spina bifida. This occurs a little bit later, but not much later. So what do we see? The number one presenting symptom is back pain, but we also see lower extremity weakness. You may have muscle atrophy, may have problems with gait, sensory deficits. The patients can be low tone or high tone. They can be hyperreflexic or areflexic. Bowel and bladder dysfunction is kind of the least common denominator of tethered cord. Almost all of the patients with tethered cord will at least have constipation or urinary frequency or urgency, frequent bladder infections. And by the way, in a male child, that is very, very unusual. That should prompt concern for a neurologic problem. There may be a mass, a large mass. A lot of the time there's a deviated gluteal cleft, and the reason for that may be an underlying mass shifting the cleft. There may be the midline neurocutaneous signs or signs on the skin, dimples, sinus tracts, tufts of hair. Hemangioma is just a discoloration. Scoliosis is related to tethered cord. If it's not taken care of course, you won't see that initially in a baby, but you'll see it as the child grows. And it's very common for a teenager to present with scoliosis. I get a lot of patients from the orthopedic surgeons who are fortunately very, very attuned to this, and when they see a child with scoliosis, they almost always get an MRI to make sure there's not a neurologic cause of it, which may be either Chiari malformation very commonly or tethered spinal cord. Foot deformities, hammer toes, very high arches, and then of course back pain, leg pain. In kids, the knee pain is a lot of the time attributed to growing pains. But when it goes along with other things, then you have to be suspicious of tethered cord. Sometimes you have limb asymmetry, the one leg bigger than the other, smaller. Delayed motor milestones in babies, very, very common. If a tethered cord is severe, they may actually present with Chiari symptoms. So, for example, we had a young man last it's about 2 years ago now, 15 years old, who actually presented with headaches and central sleep apnea, neck pain, numbness and tingling in his hands. MRI of his brain was normal. MRI of his spine revealed a tethered cord. On further questioning, yes, he had urinary frequency and urgency. Yes, he had neck pain and back pain. He had exhaustion from waking up all night from the apnea, but he also had pain into his arms and legs. A kid may not even mention numbness and tingling in the hands and feet because they think everybody has that. They think that's just normal, but you have to put it to them a little bit differently. Does it always feel like bugs are crawling on your legs? Yes. Do you have a feeling like buzzing in your feet or like something is crawling up your legs? Yes. And what they're describing is paresthesias. Okay. So bottom line, tethered spinal cord is a clinical diagnosis. We do different studies to diagnose it. The gold standard is an MRI. We can do a myelogram if for some reason someone can't get an MRI, like a pacemaker or something like that. Urodynamics help if it's very subtle. On the other hand, if someone is having accidents and they're not drinking a lot at night, and it's not only happening at night, and they are over the age of about 4 years old, it's abnormal. So even without urodynamics, that this is a person with neurogenic bowel and bladder. EMG and nerve conduction studies can rule out other things, but the bottom line, this is a clinical diagnosis. MRI doesn't tell me whether someone is tethered or not. It tells me where. So I've already decided someone is probably tethered by putting together, if it's a baby, let's say, the sacral dimple, the asymmetric legs, the delayed milestones, and then I'm getting an MRI to see where in the spine the problem is. So this was a 2-year-old girl who had always had these very high arches. And, little kids, toddlers are always clumsy because they try to go faster than they can go. But she was actually getting worse as she got older instead of better. And her left calf was visibly bigger than the right. You can also appreciate the bruises all over her legs from falling all the time. Here, her MRI shows her spinal cord seems pulled very straight and to the back, with a little short phylum right here, tethered right here. It doesn't follow the normal contour of the spine. And then if you look at the crossways films or the axials, you see her thickened phylum right here. It's bigger than any of the other nerve roots, and it's pulled right to the back. So she was tethered and underwent spinal cord untethering. So there's a range of what we might see when we untether somebody. This is, a more complicated one. This is spinal cord. This is scar. And when you get into it, sometimes you can't even tell what's scar and what's spinal cord. This would be someone who might have open myelomeningocele, who has extensive scar, and the spinal cord is scarred to the placode where it was repaired. Or this could be someone who's had to have spinal cord untetherings over and over again. This is what we would see. But, ultimately, we can get the spinal cord free from the surrounding tissue. Even though it's scarred, it's free. Sometimes it's very focal. This one was just tethered right here, and then this is the normal dura, kind of ballooned out, and you can kind of appreciate the nerves underneath, but it was tethered right at this spot. Okay. Sometimes tethering can be so severe that it actually yanks the spinal cord down and the nerve roots are going up. These are the holes that the nerve roots go out into, and instead of them coming down like the cauda equina or the way draping down the way they're supposed to be, they're actually going up because this tethering was so severe. Here the phylum, or the end of the spinal cord, has been divided and everything is free. We do see a release a lot of the time when we untether the spinal cord, but it doesn't go back up to normal position. And this spinal cord will not rise straight up. So when we get MRIs later, it'll always be read as showing a low-lying spinal cord. It'll always be low-lying. So again, there are more subtle things that we look at the MRI is, their fluid all the way around the spinal cord. Does it look stuck to anything? But it's a clinical diagnosis above everything else. So some of you have probably heard about fetal repairs for open spina bifida, and that's been very successful. It's been done as part of a research study, the MOM study, across the country. And, I have sent probably about 12 kids to the different centers during the course of the study, kids who would have been about L3-4 level, meaning that they would have hip flexion and may be able to bend their knees or straighten their knees, actually walk and move their feet and toes like there's nothing wrong. But the problem is when you close very, very primitive tissues like that, you're even more at risk for tethering because those tissues just heal very, very well. So this is an example of an epidermoid tumor, which is the result of primitive mesenchymal cells getting into the spinal cord and then just growing out of control. These are cells that would have become skin, maybe hair. This child had this whole mass of blonde hair in her spinal cord. And of course, this is an example of a mass that is a tethering mass. Okay. So what happens in this schematic of this, in this drawing, is what happens when the spinal cord and the dura don't roll up the way they should. These mesenchymal cells here, primitive cells, during embryonic development, can get into the center of the spinal cord and just start growing out of control. And this is what leads to the spinal cord lipomas, or some people call lipomyelonmeningocele, which is another type of tethered spinal cord. Okay. This is an example of a dorsal spinal cord lipoma. You see the spinal cord coming down here. You can appreciate that the bottom of it is low. This should end about L1-2, about up here. And it's pulled down to about L3-4. And then you have this bright signal here. Here you see the lipoma. This is the actual spinal cord and the nerve roots coming out, and then behind it, this bright lipoma within the dura. At surgery, we see this lipoma here. This is the phylum, the end of the spinal cord, and the lipoma is growing out of it. So here we've resected the lipoma and cut the phylum. That's very important. And then you just see the nerve roots coming down free now. A little more complicated type of spinal cord lipoma, transitional spinal cord lipoma. Spinal cord is coming down. The lipoma, or the fatty tumor, is here coming out of the spinal cord, and it blows out through the dura, actually out into the soft tissues, into the fat sometimes. And so that's a pretty extensive resection. To untether this, the goal is actually to separate the spinal cord from whatever is causing it to be tethered. The goal is not necessarily to completely resect a tumor or a cyst or a lipoma, particularly if you know it's benign. So this is the actual untethering here. But then we go ahead and resect the lipoma back to the level of spinal cord tissue and free the nerve roots from the lipoma, which in a transitional spinal cord lipoma, they're also involved. We also like to remove enough of the lipoma that it won't just retether to the spinal cord. Okay. So this is another baby, a newborn with spina bifida like the one I showed earlier. But then you see this tuft of hair here. It's midline. And it's very important in these kids to get a full body study. I always look at the full back, looking for any kind of midline signs, because they can have more than one thing. That tuft of hair was overlying this very subtle kind of hook that you see here. So in addition to the open spina bifida below, down at this level, she had a split cord malformation. 2 spinal cords, the right side and the left, and all of the nerve roots on the right come out of the right half, and the nerve roots from the left come out of the left. This is by definition tethered. If you've heard someone saying that they have a split cord malformation, they are by definition tethered. If they've never been untethered, If they're an adult, then you have to decide, how symptomatic are they. If they don't move their legs or they move their legs asymmetrically, which is very common, we're not going to change that from birth. But if they've had a loss of movement or strength in the last year or so, a change in bowel or bladder function, or if they're constantly in pain, they can benefit from untethering even if it wasn't done as a young child. And again, 2 types of split cord malformation with the bony spur that my little patient had there, or which is type 1, or with just a membrane, which is type 2. Okay. And then at surgery, this is what you see, 2 spinal cords, the nerve roots from one side coming out here, and the nerve roots from the other going that way. They are tethered at the split here, so that all has to be taken down. But you also have to follow these down to the bottom of the phylum, the bottom of the spinal cord where no more nerve roots are coming out, and cut the phylum too. Otherwise, it's not completely untethered. Now, if that's not enough for this little baby, actually, this is a different patient. This is a 17-year-old who came to me who really had always had this little tuft of hair and this lesion in the middle of her back, about mid-thoracic level. And her, growing up, her father always thought this was abnormal, but he couldn't get anybody to really look or do a study or do anything about it. And at 17 years old, her only deficit was that she couldn't move the pinky toe on one foot. Well, it's not really disabling, right? So you wouldn't necessarily explore her for that, but you do get a full spine MRI, and what you see is this kind of shadow here and here. The spinal cord is also shifted over to the left from the right, and there's something going on there. Okay. At surgery, this stalk, which is called a manqué, which sometimes you see this in tethered spinal cord, was extending straight down from that little tuft of hair and that lesion, so that was a sign. There's a problem right here. And it was leading straight down to this mass inside the dura, compressing the spinal cord. This is a neuroenteric cyst, and it's very commonly found with split cord malformation, which she also had down below. So I removed the cyst. I actually did not untether her down below. We decided that she really, wasn't very disabled by just not being able to move that one toe. It's a big operation to go through. She actually had normal bowel and bladder function. But when you see a mass, you may think it's a cyst, you may think it's something, the radiology report may say what it is. You don't know what it is until you get a piece of it. So that had to come out, but that was benign, and she did well. Okay. Now I showed this just to show normal versus abnormal caudal agenesis. This is when part of the sacrum or the coccyx or the coccyx just doesn't form at all. So this baby has a problem up here, which is something else, but down below, this is pretty normal. You see the spinal cord, and again, you can appreciate the spinal cord is following the curve of the spinal column. It's not yanked to the back or doesn't seem to be stuck anywhere, and then the nerve roots are just draping down, and he has his full sacrum and coccyx. Here, we follow the column down, and it just kind of ends right here. So this is caudal agenesis, and these are also by definition tethered. When we see a baby with caudal agenesis, and there'll be a hook sign when we run our hand over the back, because there's no tailbone, everything just stops. And these always have to be untethered, or should be. Again, if someone comes, later in life, they've always had this, they were told they weren't tethered, do I need surgery? Well, not necessarily. If you're not symptomatic and you're grown, then we figure that out. But when I see a baby with this, always, I untether them. And what we usually find with caudal agenesis is a thickened phylum like this. So a little more simple. This is spinal cord, the nerves coming down, the thickened phylum, which should be thinner than the nerve roots, not thicker. And then here, we've separated it from all the nerve roots, no more nerve roots coming out, and then cut it. Okay. So just a note again about normal versus abnormal, because when you're talking about subtle tethered cord, a lot of the examples I showed are pretty, obvious. But when it's more subtle, someone can be very, symptomatic, but the spinal cord will not be pulled down low. There won't be a big mass. There won't be, some of the sort of traditional findings. This is a 12-year-old boy who came to me with back pain. And I thought this was a very good example of normal. Again, spinal cord in the center, fluid completely circumferentially around the spinal cord, and the nerve roots just draping down. Here, the spinal cord is not pulled down, but it's angled backwards. And there's just a sense that the phylum, or the end of the spinal cord, really wants to be completely dorsal within the canal, as opposed to just coming down and being surrounded by the nerve roots. The axial view, this is my normal 12-year-old, there's the phylum in the center, surrounded by all the nerve roots. Here, this boy's phylum is pulled back. So he was tethered. And those are some of the things that we look for when we're looking at, a more subtle picture. So there's been a lot of, in the literature, about subtle tethered cord, or what we call minimal tethered cord, thickened phylum, or just a tight phylum. Might not even be thick. It just may look like it's pulled under tension on MRI, and those are the only findings we have. Nate Selden out in Oregon, in this paper, described untethering the phylum in patients whose MRIs were actually normal, who had neurogenic bowel and bladder. And of those patients, 70% regained normal bowel and bladder function. They couldn't keep doing it that way, because that meant 30% were untethered and didn't get any better and had a normal MRI. So that's something that, going forward had to be done within a study. But again, it's a clinical diagnosis. Okay. So this is a lady that was very recently done. She had had a Chiari decompression about 6 years ago, and most of her symptoms had gone away. But then over the last year or so, she started having a recurrence of headaches, neck pain. Her mother was with her. I love it when the moms come, because they give me all the birth history and developmental history on, adults that they don't know. And she told me this lady had always had weak ankles. And she had a lot of fractures in her legs because of these weak ankles growing up. Always had neurogenic bowel and bladder, still does, and back pain, and pain radiating into her legs, numbness and tingling in her feet. The spinal cord is pulled very straight here within this canal. And you can appreciate, or I don't know if you can from there, the phylum pulled dorsally. So I thought she had a thickened phylum. This is at surgery. This is actually her phylum, not her spinal cord. Her phylum was as thick as a spinal cord and as fat. And then here it is untethered with the nerve roots coming out. So again, our films don't always tell us the story. But, if the clinical picture is suggestive, then we go ahead and untether them. This is a 6-year-old who had a known spina bifida, who had neurogenic bowel and bladder, and we actually explored her as part of the nerve rerouting study that we were doing here a few years ago to restore normal bowel and bladder function to kids who didn't have it, who had spina bifida. When we opened her up, and I'm showing a very straight spinal cord here, everything pulled dorsally, it looks as though it's tethered right there, and it looks very tethered here. At surgery, she was not tethered. She was also not symptomatic. So that's how important that is. We were prepared to untether her, but recognizing she didn't have, tethered symptoms, we just did the procedure. Okay. So tether cord, comes in all different varieties. Every patient, I think, is different. I have so many pictures because every case shows something different. And just in terms of tether cord, Chiari malformation, problems that are not that well understood by everyone. I know a lot of you are going through a lot of trouble and a lot of hard times, and when you are in the midst of it, it's very hard to see daylight. But answers are out there, and you just have to persevere and keep trying and don't give up and don't take no for an answer. And things will get better. Thank you.